The COVID-19 pandemic came as a big surprise, and the medical community needed to act very quickly. In view of the mortality, the morbidity and the mortality related to COVID-19, a lot of measures were taken, and those measures focused mainly on the viral pandemic itself. At the same time, of course, other healthcare systems have to continue. Oncological healthcare is currently a large part of healthcare overall. And in view of the pandemic, we needed to reduce our contacts with the patients for a number of reasons. First of all, every patient contact has in it a viral transmission risk. Secondly, we, to be honest, don't know what is the interaction between the virus and the oncological situation and the oncological treatment. Third, we were faced with a reduced capacity, real one or even an obliged one, due to the shift of infrastructure and healthcare providers to handle the COVID-19, which was really given as the first priority. For sure, the virus poses a risk for breast cancer patients, first of all, because having a cancer is a comorbid situation, and patients who have active cancer might be more vulnerable to complications of the viral infection. Moreover, patients under active treatment, which is often immunosuppressive, were expected to have a higher risk of serious complications due to the COVID-19 situation. Another situation was that a lot of the patients with breast cancer who were under treatment or under follow-up feared to go to the hospital, fearing for viral transmission, of course. Moreover, treatment capacity was reduced. Intensive care units were completely taken up by COVID patients. Surgical wards were closed. And the fear, of course, for the immunosuppressive effect of, for example, chemotherapy. In our roles as healthcare professionals and, of course, breast cancer experts in this perspective, we needed, therefore, to take all measures to minimize the exposure of our patients to COVID-19, at the same time respecting the importance of the oncological situation. We should not allow that oncological outcomes would become worse due to the pandemic. For this, we shared experience, and we took a lot of emergency guidance for breast cancer patients, just like for other oncological patients. The European Centre for Disease Control defined several scenarios depending on the severity of the COVID-19 outbreak. At the same time, not parallel, but to match it, we made risk stratification for breast cancer patients. So the lowest risk are patients who are in follow-up, have no active treatment, or are on adjuvant endocrine therapy alone. Then there are the patients who are suspected of having breast cancer or recently diagnosed, but not yet on any cancer treatment. And then the third category are breast cancer patients who are on active treatment, especially chemotherapy, immunotherapy, but also the other systemic therapies. We assume that radiation therapy and surgery pose less direct risks. However, every hospitalization inherently has a risk for transmission of the viral infection. So the priorities for the diagnosis and treatment of breast cancer, first of all, include that the patient should be fully informed and follow the measures taken for prevention of viral transmission, including social distancing and the use of personal protective equipment. Before the patient comes to the hospital, a pre-screening at entry of the hospital, or if feasible by phone, should be performed as well. If hospitalization or treatment is required, this should be done in a COVID-19 free hospital, or at least a COVID-19 free department or region within the hospital. During the hospitalization, no visits are possible. Multidisciplinary tumor boards should be organized in a virtual way. Staff should be working shift, all to reduce the risk that a lot of healthcare workers get infected at the same time. In the early phase of the pandemic, very little testing was available. Now we have much more testing. Whenever possible, it should be done. Concerning breast cancer screening, no routine screening is necessary up to the end of the pandemic. If it takes too long, of course, we have to revise this. And when we come to the treatments themselves, we have to favor treatments that reduce the number of patient visits to the hospital or to the department. For example, in radiation therapy, hypofractionated treatments have much less risk of transmitting the virus, so should be, even not yet applied in the clinical guidelines, applied as much as possible, on the condition that the information, the evidence that we have, show that at least it is not harmful comparing to the old standard arm, and providing that all the conditions, like in the studies done to show that hypofractionated radiation therapy is equivalent, are met. Early stage breast cancer patients with risk factors often receive nowadays primary systemic therapy to anticipate the benefits of the adjuvant chemotherapy, and in a lot of occasions also to facilitate breast conserving therapy afterwards. Now, in view of the assumed risks inherent to the immunosuppressive effect of chemotherapy, we see a shift, less primary systemic therapy and more primary surgery, followed by adjuvant chemotherapy later on. For all circumstances, the number of hospital visits have to be reduced to the absolute minimum. For surgery, daycare as much as possible. Surgical approaches that increases the risk for admission to an intensive care unit have to be reduced as much as possible. Low risk patients might be suggested to have endocrine therapy to start with and postpone the surgery for a couple of weeks and, depending on the circumstances, even a little bit longer. For radiation therapy, we have to reduce the number of visits, so the complexity of the radiation therapy and the number of fractions. Therefore, we suggested as radiation oncology community in a paper in Clinical Oncology to use the fast-forward schedule where low-risk patients, breast-only treatment, receive the entire radiation therapy in 5 fractions over 1 week instead of the old standard 15 to 16 fractions over 3 weeks, or, like is still commonly used in some countries, 25 fractions over 5 weeks. The priorities and recommendations for treating patients with metastatic breast cancer have been summarized in tables 2 to 5 in the recent paper in the breast. So depending on the circumstances related to the COVID-19 pandemic and to the breast cancer situation, under control, maintenance treatment, or new symptoms, have to be taken into account to choose the treatment which has least hospital visits, decreases the risk for immunosuppressive effects, and maintain sufficient oncological efficiency. So, for example, for palliative radiation therapy, in general, a single fraction, a high dose fraction, gives as good results as a more protracted schedule. And if the results are not sufficient, a second treatment can be given. This, in an important way, reduces the viral transmission risk. Similar for chemotherapy, often alternative schedules may apply for a certain circumstance, and in that case, we prefer treatments that can be given on an outpatient base, oral treatments, for example, or that are connected to less hospital admissions for chemotherapy administration. One of the items we are sure of with the COVID-19 pandemic is that people who are older, who are male, who have comorbidities, and who are smokers or former smokers, they have a higher risk of severe complications due to the viral infection. So cancer in itself is a comorbidity, and pulmonary respiratory comorbidity is another one. So yes, we should take into account patients who are elderly or have comorbidity, especially pulmonary comorbidity, that they are in the highest risk group of getting severe complications due to the viral infection. Now, I think that we can say that we are very happy that we have to some extent telemedicine and other IT tools to minimize or to reduce the contacts between doctors and patients and among patients. The nicest and most applied example is, of course, the multidisciplinary tumor board that is held in general using video conferences, but also patients should be encouraged to phone the doctor instead of to make directly an appointment for a live visit. Patients can be also contacted by the doctor to replace routine follow-up for non-risk patients. Also to evaluate side effects of treatment. This can be done by phone, and only the patients who have side effects can subsequently be seen by the doctor. The psychological effect of the combination of having cancer, being treated for cancer, and the COVID-19 pandemic should not be underestimated. All three circumstances by themselves are already quite a burden, and combined this increased the burden. It's therefore not a surprise that we have seen that often patients seek attention by the healthcare provider late. So delayed diagnosis, delayed advice seeking in the case of complications or complaints. On the other hand, patients who are scheduled to have routine visits are often postponed. And sometimes at those routine visits, the very important patient-doctor contact contributes to the psychological well-being of the patient. The COVID-19 situation is very serious, but oncology is very serious as well. And I can imagine that a lot of healthcare workers and patients have the impression that now everything has to go aside for managing the COVID-19 pandemic. Surgeries that have been delayed, other therapies that have been delayed or even postponed, cancelled, and now we have to catch up. So we assume that in the coming months, after the pandemic is, let's say, has had its worst phase, we will have like a tsunami of delayed healthcare seeking by oncological patients. The same goes, of course, for cardiovascular diseases. Every type of research is resource demanding, both in terms of infrastructure and in terms of staffing, time and money. In a situation like now, the COVID-19 pandemic, a lot of resources are drawn to the management of the pandemic. That means that less resources are available for research. How to handle this depends on the organization of the country. Some countries temporarily interrupted recruiting into clinical trials. Other countries decided to, depending on the phase of the study, depending on the impact of the study, to continue certain trials or not. And then, as I alluded to before, in some circumstances, we can choose for the experimental arm when the experimental treatment arm has less risks for viral transmission on the condition that no evidence is available that it might harm to the patients. And of course, on the conditions that the experimental treatment arm can be given in optimal circumstances. There is an important message. We give the pretension that we know a lot about the COVID-19 pandemic, about the interaction with cancer, about the interaction with cancer treatments. This is not true. A lot of the advices, nearly all guidelines, are based on expert opinion. Evidence currently is lacking for nearly everything in this complex interaction. Will cancer increase the risk that the virus, the infection, will go to the real disease and lethal complications? We don't know. It might be that some anti-cancer treatments prevent the severe complications due to the virus. We don't know. Will the COVID-19 pandemic negatively influence the outcome of the oncological patients that were handled with in the first quarter, in the second quarter of 2020? We don't know. We will learn this in the future. A lot of research is currently ongoing, registering data, following the patients, and I am very sure that in a couple of years we will have a lot, but not all answers to those questions. What I fear, but also this is not confirmed, is that in a couple of years we will see an excess mortality due to COVID-19, a decreased mortality due to other circumstances, for example, which is already now seen, less pollution, less traffic accidents, because nobody is on the road. But it might be that in a couple of years we also see an excess mortality because of suboptimal managing of, for example, oncological or cardiovascular diseases. This is work for now and lessons for the future. Thank you very much.